Yes.
Okay, fine. Yeah, at the beginning, I really want to thank the organizers of this event that I got the chance to speak here, because at first, and not to forget it, I really want to give my congrats to IHE-Europe for the 20th anniversary. As a lot of the people here in the call, I just reviewed the list, will remember, I was very honored 20 years ago to start a little bit earlier together with Professor Bertolt Wein, the IHE initiative in Germany, and he was one of the first co-chairs of IHE-Europe also, and it was a very good time 20 years ago to start all that, and I'm very happy that we not only started it, but we only can take care of it today. That the success of IHE International, IHE-Europe, and IHE in the national bodies can go on. So thanks for that. And now I want to give you, as it was mentioned in the agenda, an update to the national policy on interoperability in Germany, to the landscape of interoperability we see actually in Germany. To make you a little bit more familiar with the things we do in Germany, I want to try, and I know it's not possible, but I want really to try to give you an overview about the German health systems in a nutshell. Germany has a long tradition in creating a national health system, and as most of you will know, and the situation today is that we have more than 87% of public insured residents in Germany. Some more 10% are privately insured, and then 1.8% is Michelangelo's people that are uninsured, or people that will be paid for their health services by other agencies. And on this base, the public insured people, as we see it in the mid of the slide down, they get automatically, if they are working as an employee, 7.3% of their gross income will be transported to their public health insurance automatically. And the same amount of money, also 7.3%, has to be paid by the employer. So this is where the money comes in. And the public health insurances, and we have more than 100 in Germany of them, officially certified, then has to forward these contributions to a national health fund. There are meanwhile also some tax money that's also coming to that health fund, but not so much. And only little additions come from the employment agency, the National Employment Agency, for people that are unemployed and have no insurance, and also for pensionists, they have their own insurance that will pay also partly on this health fund. And at the end of the day, every year, 222.2 billion euros are the budget of this health fund. And then the funny thing is that then the money from this health fund goes back to the public insurance. And there they get refunded from this national health fund per insured person that they are working for. And then they have to negotiate with the healthcare provider organizations. And we have there today almost a strictly differentiation between hospitals and ambulatory services. So they have negotiations every year with these organizations how to reimburse them for their treatments and medication and so on. So this is the overall structure of the money flow, but this had also, and therefore I wanted to show it to you, this has also tremendous influence to what we will see in the next slides. Because based of this funding system, we have a structure, especially with focus on interoperability, that acts a little bit like this. Yes, there is a very important role of the Federal Ministry of Health. And years ago, more than 20 years ago, meanwhile also, the Federal Ministry of Health decided to create by law an organization called Gematic. You may have heard about it. This is a not-for-profit organization company that was created at that time at the beginning with a very over 50% holding from the public insurances. Meanwhile, only 2 years ago, there were some changes in the regulation. So meanwhile, the Federal Ministry of Health owns 51% of this organization, Gematic. And the public insurances, the KBV, that's the organization of the GPs in Germany, not the medical organization, but the refunding organization, then the national organization of the hospitals, of the pharmacists and others also are involved in this company with the percentages you see here. And also very important for interoperability is that the Federal Ministry of Health with the actual minister decided 3 years ago to create an organization called Health Innovation Hub. And this organization is on one hand consulting the ministry and other organizations, also Gematic and others, in doing their things, in creating strategies, and also strategies in respect of interoperability in Germany. And now the situation developed in a way that the Gematic is from the beginning responsible for what we call in Germany the telematic infrastructure. So they made specifications about how we can connect technically hospitals with GPs over a centralized infrastructure and all these things, what technical services are needed for that. And in the ongoing development of Gematic, then they also became responsible not only for the specification, but also for the certification of things, of products that follows the specifications. And to be honest, in the first decades of this organization, interoperability was a very proprietary issue. Not really a lot of international standards or terminologies had been used at the beginning. This changed in the last years a little bit, or a lot, would some others say, when Gematic, for example, started to define the national specification, like we saw it from Stefan in Switzerland with the EPD. In Germany, it's now called EPA, Electronic Patient Akte, or Electronic Patient Record to say. And this specification uses in its interfaces also IHE XDSB and some other IHE profiles. But to be honest, in the internal architecture, technical architecture, it's not really IHE conformant. It only uses the interfaces for that. And these now, with the beginning of this year, available electronic patient records has to be provided by all public insurance companies to their members. That means since the 1st of January this year, every German resident that is public insured has the right to go to his public insurance and ask for his electronic patient records. And so they have to open it and they have to give him an access to that. And then he or she can manage this record, can decide what organizations may have access to the record, of what kind of documentations. At the beginning, from the specification, the organization Gematic only worked on the specification for the infrastructure because that was their duty. And meanwhile, then also the Ministry of Health saw that there is a lack of information because if you only take care about the infrastructure, nobody takes care about the content. So actually, from the specification point of view, you can put in PDFs, TIFFs, GIFs, JPEGs, graphic formats, but also a lot of other formats that really does not make really sense. So some years ago, then there came the second decision to say, okay, the ministry made a regulation that enforces the KBV as an organization of the GPs to define and specify the content profiles for specific technical documents. And they built it out, or they founded a company called MIO42. MIO stands for Medical Information Objects, and 42, I think the most of you know what that means, coming from a very famous known movie. And because 42 is there the answer to all questions. And they decided very early, 3-4 years ago, that they will only use FHIR as a standard to make their specifications about content, document-based content in these use cases. We will come later on that, what they did till now. And now there are regulations in place or coming up that says that from specific dates on in the timeline, the primary information systems like GP systems or hospital information systems are forced to create these kind of documents. And if the patient wants to have them and opens his electronic patient record to that institution, then they have the duty to transport, to copy these documentations into his record. But there are also a couple of new services or other services now provided by the Gematic. KIM is an example where they also did what they did the years before. They provided a specification about its acronym of communication in medical circumstances. It's an email specification about a very, very secure email implementation. And meanwhile, we have 8 or 9 implementer organizations, companies that implemented the specification and now provides for all doctors or organizations in the healthcare environment of Germany the secure email service. And it's widely used, and it will become very widely used in the next year. Because starting with next year, again, the KBV organization that is also responsible for the reimbursement of all GPs in negotiation with the public insurances, they will change their technical infrastructure, how a GP communicates his billings to this organization via KIM from next year on. So it is foreseen that next year, not only the GPs, but also the hospitals will integrate into their primary systems or secondary systems, the KIM service as a secure email service. Another, and that is very interesting thing, is nearly same like as Stefan showed from Switzerland, is ePrescription, but where Switzerland is really thinking in a very good overall way, Germany restricts the things and to the ePrescription service. And what is politically very new to this decision, this service will be the first service that will not be only specified by Gematic, not be only certified by Gematic, but also only provided by Gematic. That means Gematic will be the only provider for the national ePrescription service. And all primary systems, all IT systems in healthcare that want to create ePrescriptions has to communicate with this central service. And the second decision in this ePrescription story is that Gematic will also be the only specified and certified organization that will provide an app for the user, an app for the patient, for the people in Germany that they have then to use to get access to the EPrescription service. This is a new thing on the political landscape of interoperability, and we are looking very interested, let me say it like this, to this development of our systems. And there are not only a few people that fear a little bit that this direction may be not the right one. What we could reach out in the last years is that especially the very good coordinated working standardization bodies in Germany and other organizations really work very good together, like IHE Germany, like HL7, the DIN as the standardization body of Germany, the GMDS as the medical informatics organization, and the BVITG as the organization for the vendors of healthcare IT in Germany. They work together in the Interoperability Forum. And what we could reach out is that the ministry and also the Gematic were willing in, meanwhile also the KBV, that we have something like a semi-public balloting system. We call it in Germany put into conduct. So all these organizations like Gematic, like KBV, like others that create specifications on the interoperability level has by legal regulations the given thing that they have to put these organizations here down into conduct. So it's not really a transparent balloting like we know it from HL7 or like we see it in our process in IHE, but it's a first step to ensure that before these specifications, especially here for the content profiles, for example, before they get public and regulations, we have a chance to review it and give our feedback. It's not sure whether our feedback will be then used, but we can do it. What has been done? Gematic made specifications and certifications, I explained before. And now I explained the situation about this new added value services, ePrescription. And there is another service also announced that will come up in the next 2 years. It's called TIM, not Kim, but TIM. It's a messenger service for professionals. And this will not be, in the moment, not be provided as a service by Gematic, but as a specification. But we will see how this will work out. The Mayo 42 organization, as a daughter from KBV, worked now on several specifications for the clinical contact. We have an immunization status document. We have a pregnancy document because we have a long-lasting service in Germany for all pregnant women that they can make use of a special documentation about scheduled therapies and scheduled diagnosis in the time of their pregnancy. And after the baby is born, the newborn documentation goes also on. There are 9 specialized treatments or events that will be documented in such a document. And this is now also digital possible. Also, they created a dental document. Why? The reason is a refunding thing. As a public insured person in Germany, I will not get the whole reimbursement for my dental treatments. But if I can document that I used the yearly services to get a check about my dental situation, and if I can document that over the last years, I get more percentage reimbursed of the costs that may happen than if I could not document that. And that was also one thing this organization now specified as FHIR documents, FHIR-based documents, and now a lot of these documentation will be used in the next years to fulfill the electronic patient record. The problem that what we see in Germany is that this organization is not not really able on one hand to provide all the skills that are necessary to do these specifications on one hand, and on the other hand, there are so many of these documents waiting for their specification that the roadmap is filled for the next years for this MIO42 organization. And the decision about what comes next in the roadmap comes on one hand from the Ministry of Health by regulations, or from the own perspective of the KBV organization, and that is a little bit tricky and risky, because they are strong focused only on the outpatient side and not on the hospital side. So we are not so happy with that situation, and therefore we organized last year in a collaboration between this Health Innovation Hub from the ministry, the Gematic, the Bitkom as an organization of vendors, and the BVITG also as a vendor organization, a white paper, the creation of a white paper called Interoperability 2025. And there we did not make some technical specification. What we there mentioned in a white paper is an idea about how interoperability could be involved in Germany by creating some organizations. So our idea in this group was to create a coordination instance in Germany, and that really gives all these organizations that are involved into the specification of new interoperability specifications the possibility to be streamlined in a process. Then we suggested to prepare an eHealth committee, only 15 persons that on one hand give guidance to the government for an eHealth strategy, but also is then the highest organization to make decisions when there are conflicts. And we want to set up a pool of experts that these organizations in the green area can have access to help them to specify things. And we also discussed a lot of processes in this document. Then this was a document part A. The document part B was also developed, but not really published, because meanwhile there came a new regulation from the Ministry of Health, and in this regulation the responsibility for all these things went to Gematic and KBV again. This led us to the situation that in April this year, the other two organizations, Bitkom and BVITG, again published a position paper where we said, hey guys, fine for that, and we are happy if interoperability comes forward, but we need a clear understanding about the roles, who is doing what and with what provenance and with what skills. And we fear that the decisions had been made by the Ministry of Health may lead us to a situation where especially the experts we already have in Germany are not involved in the specifications, or not all involved. And therefore, we are working hard on this. At the same time, now in April or in March this year, Gematic also published a new strategy paper. You can I showed you the link here. You will get my slides, and you can download it also in English. It's called An Arena for Digital Health, the Telematic Infrastructure 2.0, the next version. And this was very highly discussed in Germany. What is the content here? Also discussed by the organizations that built the Gematic, and it was also a conflict there, or several conflicts. Here we see again, and I really would appreciate it if you download this document and have a look into it. On a high level, it's a very good document, and it says, yes, we must have new digitalization services. We must take care about regional, national, and EU connectivity, and all these buzzwords are very fine, built together. But at the end of the day, we see also again the maybe upcoming conflict that more and more of these services that are mentioned in the white paper will be provided by a national governmental organization and not provided by the market, not provided by several market players, but only one who will be in charge of the governmental organizations to build it. And this is a danger for a free interoperable landscape. So what is for us the conclusion in that situation about the landscape of interoperability in Germany today? Yes, interoperability is very clearly on top of the agenda in healthcare IT, but we see also a descending influence of IHE profiles. They are only partly used, as I mentioned before, in our electronic patient record. They are used from the industry more and more, and there are coming up offerings of digital platforms in Germany from several industry players, and they will all use and be built on top of IHE profiles. But from a governmental point of view, then I think I must say they never really understood the importance of that. There is a clear concentration on HL7 FHIR standard, but here's also, in our view, a little bit of lack of understanding what an HL7 FHIR standard is for. And so what we, as standardization bodies, as IHE, as HL7 and others, again and again tell the ministry and the other decisioners is, hey guys, it's a good idea to use FHIR, no problem with that, but how to use it must be coordinated, must be organized, and we give the examples from other European countries like Switzerland, like Austria and others, but also from the US, from Canada and so on. But we don't see that they really go into that direction, that we need this in the white paper suggested organizations to ensure that. Another thing is that through the last regulation, there came radical changes that may occur in the follow-up of this regulation. In these three paragraphs, 371 to 373, the Gematic became responsible to make the specifications about how an IT system shall archive its data, with the idea, if you make a change of the system, the first system should archive the data and the second system should restore the data, and then everything is fine. But also the mentioned EPrescription services and infection services. Then in the next paragraph, all interfaces of GP EMR systems shall be defined by Gematic. Nobody knows what the content should be. And in 373, Gematic became also the task to specify all internal hospital IT interfaces, and also all interfaces for ambulance care services and their systems. And we're talking about interfaces in IT. And the very interesting thing on that is that these specifications shall be up and available in autumn this year. And then the IT vendors shall implement that till 1st of January next year. And this will lead to a conflict, that's very clear. I think to summarize what I showed you, we must work very strongly on the thing that we must explain and convince the organizations I showed that interoperability is not a thing of rules, it's a thing of teamwork. Interoperability is then developed when organizations, when all stakeholders work together, start to create a community and work very closely together with industry, standardization bodies, governmental organizations, and the users. We almost have the fear to forget the users. And then together we can create a situation where interoperability really can happen. Thank you very much.
Thank you, Alexander, for this very insightful explanation of the situation in Germany. So finally, things are moving. Maybe not everything is moving in the right direction, but hopefully we will be able to solve this in the coming years.
A lot of things to do.
Yeah, definitely. Are there any questions from the audience? We still have a couple of minutes left to Alexander or maybe even to Stefan. Okay, so a question from Stefan Schuk on the chat, more targeted towards IHE-Europe. There should be a special session organized with EU members about the national interoperability roadmap. That might indeed be interesting because, everybody should be able to unmute now. There was a question from Jürgen, it seems.
Okay. Tia,
okay.
from the Netherlands. Maybe it's interesting to see what is happening in the Netherlands. We are writing now a new standard. And actually it's based on a maintenance of standards, but the Ministry of Health was dealing with the approach of use cases. So what they needed is actually a standard not only per standard for HL7 or DICOM, but also in the interconnection between the standards in a use case. And they contacted me because, hey, the IHE methodology is doing that. So they asked us to give input to that standard, and it's now in a final phase. And in that standard, you can see also the users, which role do stakeholders have in this system. So maybe that could be a thing to tell governments, if you want to come to national interoperability, which stakeholders do you need? The users, Alexander, what you mentioned, you should start with the users. But how do they interconnect with the technical standards? And how are you going to do that based on use cases?
Yeah, that was a little bit the idea behind this white paper I showed about Interoperability 2025. And the problem really is that the discussion of this white paper had been very good with the ministry, with other organizations, but they did not understand.
Mm-hmm.
They denied to understand that the process is the thing, as you told it, yeah, that that the framework IHE uses to create new profiles, that is really key to come to interoperable specifications. But no, we make this organization responsible for that, and they will deliver in 6 months. End of the yeah. And we try to convince them to say, hey, you have to build up a community. You have to build up an organization that work, not own one organization, but you have to build up a framework where organizations can work together to come to that goal. And they completely denied. That's not their approach.
We are reaching a little bit the end of the time. There's still a question from Jürgen, maybe a quick one.
Thank you, Jürgen here. So Alexander, thank you very much for this comprehensive explanation. I finally got it, how complex the situation is in Germany. And,
I showed 5%.
I wish you good luck in connecting your government with the experts. I know you're trying hard.
Yes.
But my question is, in Austria, we have ELGA, and I remember these political discussions around privacy were all resulting into a strong exclusion of everything what comes along with insurances. So physicians of insurances are even banned by law to have access to the citizen's health record, like the devil does holy water, And now I see that in Germany, the electronic patient record of every patient is exactly organized by the insurance. So
yeah, but they have no access to the data. That's the really interesting thing.
Okay.
It's forbidden for them to get access to the data.
So they must host it, but they
They have to decide about a hoster and a vendor, and they are not allowed to get data. They are nor allowed to get analysis about the data.
Oh, okay. Thanks for this clarification.
So they're required to pay for it, but can't access the data.
Right. That is a principle in Germany. Yeah. The
German
Ministry of
solution.
Health does not pay any euro for all this. Yeah, but they make regulations that the insurance companies has to pay.
So I fear we have to conclude this session. We are a little bit over time already. So thanks again to Stefan and Alexander for their great talks. Next coming up, and probably already going on, is getting a similar update on what is going on in Gabon. So hopefully see you there.
Thank you.
It's, by the way, another Zoom session, of course.
Yeah.
Okay. Thank you very much.
Bye. Thank you.
Bye.
Bye-bye.